welcome to Researcher Revealed, the podcast where we go behind just the name that's listed on a research paper to get to know that person and find out why they got into research. On today's episode, which I think is episode 14, I don't know, I'll put it down here on the screen somewhere as to what episode number it is. We have Professor Joseph Manning, who is joining us. I'm so excited to talk to him. I follow him on Twitter and social. And I'm really curious to find out about how he got into research. He was recently appointed in November, I believe, of last year as a professor of nursing and child health in the School of Healthcare at the University of Leicester. And I can't wait to find out about his journey through research and what inspired him. I hope you enjoy. Hello, and welcome to the next episode on Researcher Revealed. Today, we have joining us Professor Joseph Manning, and I'll just have him quickly introduce himself.
Thank you. So, I'm Joseph Manning. I'm Professor of Nursing and Child Health at the University of Leicester. I'm also a clinical academic nurse and continue to practice as a bedside nurse and critical care outreach nurse at Nottingham Children's Hospital, and also as part of the senior leadership team in the division of family health at Nottingham University Hospital's NHS Trust.
Oh, thanks for that, Joseph. So I'm not sure how many of our episodes you've listened to or not and how nervous you are. But the first thing that we do on the Researcher Revealed podcast is the Rapid 11. Have you heard of it?
I have heard of it, yeah.
Excellent. Are you ready?
I'm ready.
Are you nervous?
I am slightly nervous, yeah.
All right, first question. We'll start off with an easy one. Are you a Windows or a Mac user?
I am a Windows user.
Okay, you're in the majority there. Tea or coffee?
Coffee. Coffee is life.
Fair enough. When you're writing, do you prefer silence, sounds, music?
Silence. But I've got two very young children, and that is it's a never event in this household.
What, the silence or music?
Yeah, silence. Silence. Okay. Music is always playing in the background somewhere.
Oh, fair enough. Fair enough. That leads me on nicely to the next question is, where do you tend to work, at home or office?
At home.
Okay. Okay. So that must be challenging then with kids.
Less so now because I do have a home office, so
okay.
Not just a spare bedroom, which I was working in for the majority of the pandemic.
Okay. Okay. And the next question I'm going to find interesting then with having children around is, what time of day do you find you're most productive?
I'm a bit of a night owl, so I think I do work quite late into the night.
So it's so interesting. So like I started these Rapid 11 questions just for a bit of fun and to like sort of break the ice. But I haven't exactly plotted it, but so many people who have children are all saying they only work at night. After the kids are in bed. Other than that, it's not really possible. So that's very interesting. Right, next question is, what is your favorite referencing system or manager?
EndNote.
EndNote. And is it actually a favorite?
I think it's probably the one that I'm most familiar with. I've not used, well, I've used Mendeley and have not got on with it. So I suppose favorite. It was the one that I was first introduced to and most familiar with, so I've stuck with it.
Fair enough. And what about when it comes to like making your graphs, your figures, images, stuff like that? What's your favorite sort of data visualization tool?
Oh, that's a great question, and I don't really know. I work with a great team of data analysts and data scientists, and they write a lot of code in Python and create lots of great visualizations for some of the statistics that we do. So I mean, I've used SPSS, but I don't think that's a great outputs on any of the figures. But I don't know what system they use, but they create wonderful figures.
So from my point of view, then your system is other people, and there's nothing wrong with that.
Team science, isn't it? You know,
Exactly.
and so yeah, I work with
Exactly.
some great people, and yeah, I'm very dependent upon them to generate some very nice looking figures.
Oh, that sounds ideal. That sounds like hashtag goal for me. The amount of hours I spend trying to make figures. Anyway, moving swiftly on. What about a favorite desk snack? Working while you
Um,
eat.
hmm. I'm a fan of a rice cake.
Ooh,
Yeah,
okay.
a salt and a savory rice cake.
Okay, nice. I don't know, I'll have to look whether or not
Oh,
somebody said that. So far, the most common desk snack among researchers is bananas,
okay.
which I'm
I'm
like,
an it's either a rice cake or a nut.
okay, fair
Yeah,
enough.
an
Fair enough.
almond.
Excellent. When it comes to planning, so whether that's life, work, a project, a paper, are you a digital person or are you a pen and paper person?
I have I had a New Year's resolution this year to become
Ooh.
more organized, and I'm a OneNote person for planning.
Oh,
Yeah,
I tried OneNote and I didn't get on with it.
yeah. I think persistence prevails.
Might have to hit you up for some top tips on that one.
I think
Okay, cool.
it helps to bring everything into one place when you've got the thing that really sort of depletes energy is the endless list of emails, and so bringing it into OneNote with documents and other, you know, to-do lists and plans is has been useful thus far. But we're only on the first of March, so
Hey, but I think if you're sticking with it and you're 2 months in, don't they say, maybe it's outdated, but don't they say like if you can manage to do something for 6 weeks, then it tends to stick?
let's hope so.
Fingers crossed.
Fingers crossed.
Um, Perfect. Second last question is what book are you currently reading?
So I do a lot of reading with my children.
Mhm. There's
So I
nothing wrong with that. We've had other
yes.
people being like reading Harry Potter, so
Uh-huh.
there's no shame here.
So I'm currently reading with my youngest child, Boy, by Roald Dahl. I don't know whether it's
Okay, yep,
part of his autobiography for children. It's a great
nice.
book, and it was probably one of my favourite books as a child.
Nice. I really enjoy children's literature, actually. I've hunted down quite a lot of like the original fairy tales, like books that the fairies, like all the Disney tales were based on, and they're so much better than the Disney, but maybe not as child friendly. It depends on how you feel about things. Oh man. Okay, last question is who is a researcher that you admire?
Oh gosh, there are so many people that I admire and have been mentored by and are inspired by. Um, I couldn't say a single person. Um, Professor Jane Code, who's Professor
Mm,
of Children and Young People's Nursing, Professor Martha Curley, who's probably one of the most influential paediatric critical care nurse scientists globally, Professor Jos Latour. Um, you know, there's loads of people. I mean, hopefully we're going to talk about some of those and how they've influenced and shaped my thinking and my career. But yeah, there's lots to be inspired by within our field, and certainly my field of as being a children's nurse and also focusing on predominantly paediatric critical care.
yeah, definitely.
Shoulders of
So
giants.
well, exactly, but I think that's such an important thing that loads of people don't really think about. necessarily. And I think that's why the question for me, I wanted to ask it in the Rapid 11 is because I think exactly what you just said. If we're going to, especially within the field of, well, any non-medic career, because I think the medics are a bit better at it maybe than non-medics are, but especially in nursing, I know that there's a previously prevalent culture of eating your young rather than standing on the shoulders of giants. And so I think it's a really important factor of being like, actually, you do need to recognize, you do need to have those mentors, those inspiration around you. And that's why I ask it, because I want to help expose other people who are out there listening to this to these other individuals, because I think some of the previous generations, prior to social media and things like podcasts and whatnot, they're not as easily visible as people like yourself. And so they can sometimes be a bit harder to find. And I just think the more we get those names out there, the more that more nurses are going to realize that this is a possibility for a career and that there are actually pretty amazing nurse researchers out there. So having a long list is fabulous. I have a long list as well. I couldn't pick just one.
Yeah, and I think to encourage early career researchers or people that are considering a career that involves research is that oftentimes people are very nurturing and welcoming. So, if you're at a conference or if you're in a networking event, or even if you're just, on the Twitter or in an email, just reach out to, have the confidence to reach out to people, because I think more often than not, they're very keen to support people. And the people that I have as colleagues and friends and have mentored me through my career have been really generous with their time and their wisdom and their expertise. And I think, we need to invest in the future, because otherwise we won't have an evidence base for our profession unless we are supporting the future generations of researchers and scientists.
Totally agree. And I've found, like, since I've moved more into the world of research, that actually exactly what you're saying, it's the exact opposite. And in fact, I had the funniest response yesterday. So with this podcast, I'm reaching out to all sorts of people like all over the world and asking them to be guests on here. And I reached out to a nurse researcher who I didn't know from Adam, who didn't know me, blah, blah, blah. And I just like blind messaged them on Twitter, and they were like, ask me to come and talk about my research? Obviously, of course I would. Because exactly that, like people are so keen to, I think, because research is such this speciality, this super niche area, and we invest so much of ourselves and our passion into it, that any opportunity to share about that, we're like, woohoo.
Yeah, and I think, it can be quite an isolating journey, oftentimes, and certainly as a clinical academic nurse, oftentimes we're trailblazing, and so making those connections and building, I think that the world is smaller now because we have
Yeah.
social media and the internet to connect with people, and so people are very keen to do that, aren't they? They're keen to have reach and to build those networks that are non-conventional, because we want to surround ourselves with like-minded individuals that help develop our thinking and where we want to go, and illuminate and open our minds to new ways of thinking and working with problems. So yeah, I get it. And I think that again sort of reinforces that people should really, if you're keen and you're eager to broker into research, then have a low threshold to reach out to people, put those big confident pants on and just send the email or write the Twitter message, because people will respond positively to that.
I like that low threshold to reach out. I like that. That's very cool. Right. Well, speaking about journeys and getting into research, what about you? So, from your background, you're still working in pediatric critical care. So, what took you from working on critical care for littles into research? What was your journey?
So I think my journey started when I was doing my nurse training. So I did an undergraduate Masters of Nursing Science programme at the University of Nottingham. And during that programme, there was a keen focus on understanding about evidence and the evidence base and the importance that was for improving patient outcomes.
Yeah.
But I think there was two people that really lit the sort of the desire
Okay.
and made me aware that actually a career that involved research was a possibility for nurses. And that was somebody who was working in the clinical domain. That was Sandra Lawton, who's a nurse consultant for dermatology.
Yeah.
And she sort of gave me some insight in the power that evidence has to advocate for our patients. So I had an insight. I wasn't with her for a prolonged period of time, but I had an insight day with her and working as a nurse consultant, and she was using evidence to inform the care planning and really sort of challenging what the plan of care was for this patient. I thought, wow, this is really powerful, how she was using evidence in this way to improve the care experience and outcome. And I thought, oh gosh, I want to do that. I was really inspired by her the way that she worked. And then the other thing was the introduction of clinical academic careers.
Okay.
And this was relatively new in the journey of the National Institute for Health and Care Research, but also in recognising that for nurses, midwives and allied health professionals, a career that had meaningful concurrent engagement in clinical practice and research was a viable career pathway. And so that was introduced in a session by one of the professors within the school that I was being trained in. And so again, that inspired me and thought that, yeah, actually that is a career that I wanted to have. And so I obviously I qualified and graduated with a master's degree, and then set off in consolidating my practice and working as a children's nurse in a number of different clinical areas, but then came round to PICU and I was like, wow, I want to do critical care. This is where you see everybody, because it doesn't discriminate whether you've got an injury or a disease or an illness or a surgical procedure. You can all become critically ill, and the practice and really the family integrated care that we were delivering on PICU was really attractive to me. And I really, I loved the practice. I loved the skills and knowledge that we had to mobilize, but also the opportunity for mobilizing the evidence base and really thinking about how can we advance that in our practice as nurses. So that's really where it all sort of started for me. It started when I was training, and that's why I'm so committed now as a professor in trying to set alight that ambition for this is a potential career, and you need to start thinking about that when you're training. Even if you think, actually, I'm aware of that career, but that isn't the career for me currently. But it may be along the course of their career that they may want to reorientate themselves to actually research maybe something that they want to do. But fundamentally, it's about instilling in everybody that everybody should be an evidence-based practitioner. And so even if you don't want a career where you're a clinical academic or a nurse researcher or whatever, that actually you need to understand what evidence is. You need to know how to mobilize that into your practice. So that, in summary, is where it all started for me.
Oh, that's so cool. I think you're one of the first people I've spoken to who actually came across it in their training. So that's really, really interesting. Most people have been saying it was like through research delivery or through audit or things like that. So it's really, really cool that for you, it was actually from the very beginning of your nurse journey. Very cool. So that's how you got into research. Now, what about your own personal area of interest. So obviously kids, which comes with a whole different set of challenges when it comes to setting up research projects. But why the, so aside from children, because you're a children's nurse, why the area that you're actually looking at researching and trying to understand better? What was it about those pathways or that central core that's in your research aims and goals? Why that versus something else?
Yeah, so I suppose at the core of my program, and I've got quite a wide, broad program now around acute paediatric care, and fundamentally the focus is on how do we understand complex phenomena. So that's
Yeah.
being unwell across a range of services, and how you transition between those services, how do we support and optimize experience and outcomes. So that's that in the broadest umbrella, where my program of work sits. But at the core of it, and where I suppose where I started, came from my clinical insights of being a bedside critical care nurse and thinking, and having conversations with parents and families, as well as my colleagues, around, well, we're very good at saving lives. We have about 97% of children that come through the PICU that do survive. So there is a shift in focus, whereas when we first created critical care environments, and it's the same in adults, it was all sort of focused on, okay, we've got to save lives at all cost. But we've shifted to this state where actually we need to be thinking about outcomes. We need to be thinking about how do we optimize, what are people's lives like once they've been critically ill? What are their needs, and how can we work as interdisciplinary teams and across care pathways to optimize the outcomes and lives of these children and families, because they've got lives ahead of them. This isn't like an adult on critical care where they may have years or at most decades. These are lifetimes, and also for children, they are part of a family unit. And so the impact of them being critically ill will be potentially on the parent and caregivers, but also on siblings and the wider family unit. So it's multiplied and also has legacy across their whole life. So that really is the focus of my work, and it was born out of the clinical insights, because we didn't have any evidence base really to inform those conversations around what would life be like for these children and families once they'd left the PICU. We'd asked parents, and so there was some evidence around that, but we'd never really explored that with children. And for me, as a children and young people's nurse, that seems a little incongruent with our practice, and so that sort of set me off on a pathway of, okay, well, firstly, we've got to really try and explore the phenomena from the views and experiences of those people that have that lived experience, and that's children and young people, and that's challenging because children are on a developmental trajectory. They're also have a period of significant maturation and growth around capacity and ability. And so the conventional ways in which we try to elicit, the views and experiences of potentially verbally articulate and people that have capacity are not those methods or tools that we can use with children. So we need to think differently. So that's where in my research I've used some of the seminal work that Professor Jane Coates developed around using art-based and participatory approaches with children and young people, as well as a whole range of other methods, so that we can understand the phenomena. And then a whole program has been built from that, using mixed methods in conceptualizing phenomena. And we've developed the post-intensive care syndrome and paediatrics framework, which has now got international utility within science. It's been used for core outcome set development, and certainly a number of prospective cohort studies where we're trying to map outcomes over time. but also it's having clinical utility. It's enabling us as health professionals and as nurses to articulate to parents and families and to children, you know, what outcomes you may have beyond the intensive care experience.
Yeah, I think it's an area that I find very fascinating, but I also very quickly feel like I get out of my depth because like you say, like the level of complexity that's involved because of family, because of the child, and then the child's level of development and the layers of complexity that's around that. What I will do for everybody out there listening is in the episode description, I will link in Joseph's papers and publications, a few of the top ones, as well as his link to his full profile, so that if what he's been talking about is really fascinating and you want to hear more about it, you can dive into some of his research. But I would also encourage people, like I did a course on creative methods because I was inspired by a presentation of Rhiannon Jones here at the University of Southampton, and she used art with children to talk about their health journey with chronic pain, undiagnosed chronic pain. So I took a creative methods course, and it's really fascinating. Just the different ways that we can collect evidence and understand people's experience based on different methods, and you can use it in adults as well as children. So maybe sometime in the future we might have to have you back for like a methods masterclass.
That would be great. But I mean, again, we're standing on the shoulders of giants, and Jane Code, Bernie Carter, Professor Bernie Carter from Edge Hill University. I mean, Professor Faith Gibson. These are the children's nursing professoriate that have sort of paved the way for the methods that we're using, thinking differently. And I think, you know, oftentimes within the literature, it sort of it's portrayed as an inferior approach, and I think these are robust methods. They're tried and tested, and also there is a systematic approach in which they are used to collect data, but also to analyze the data that's elicited. So I think, yeah, that would be great to have some sort of dialogue around the method and you know, think differently as to, because it's not just for children, you know, capacity issues, issues around language and understanding it transcends the life course, and so it does have utility for people working in different areas with different groups of people. And I think we haven't really fully maximized the potential of using these creative, really, you know, sort of participatory approaches to really understand the evolving and changing needs of the populations that we serve.
And I think currently in research worlds, I hear more and more talk about altering the outcomes that we capture and have them be more focused on what's important to patients, because for so many years before, probably even both of us started our research, it was the only outcomes that were important were, are you alive or dead, and are you in hospital or not? And we're starting to realize as our evidence base grows that actually those may not be, they might be important for the bankers, but they're not actually that important for clinicians as well as for those patients, that there are other things that they rank a lot higher. So I think like you said, like using different methods that have been systematically developed, that do have robust methods of analysis around them, you know, is only going to help expand how much better we're able to capture those important outcomes for the people that we're trying to change care around. So yeah, no, it's fascinating. I've made some notes, so I might be reaching out to some more people. Perfect. So it's so interesting. And I would love to deep dive into your research a little bit more, but I think what really fascinated me about what you said, more than anything, was how your clinical exposure was the thing that made you passionate about better understanding those outcomes for these kids that you were and their families that you were caring for in the hospital. And that leads me on to this umbrella term. And in the episode, I think the one right before you or the second one, anyway, I'll link in the description which episode it is, where we actually started to talk about what is this thing that we call a clinical academic, and how does that translate for PICU nurse, regular nurse, and how does that work? So tell me about your journey as in becoming a clinical academic professor in pediatric research.
Yeah. Okay. So yeah. So as I say, I was introduced to the career pathway, although there wasn't a defined career within the organisation that I was in when I qualified as a nurse. And so I did, like many people, consolidate my training, came around to PICU, found my love for the specialty, and did a specialist qualification within that. And then I got involved in a number of activities that are on the research continuum. So I did some
Okay.
quality improvement work, and I did some service evaluation work. I also worked as a research delivery nurse within part of my role. And I think until now, I think we're starting to really understand the expertise that the research delivery workforce bring to the healthcare ecosystem and also to research. You know, so all of those skills that I had in understanding and setting up, you know, a clinical trials, which is what I was working on, and research ethics and good clinical practice, and, you know, training staff, orientating, doing these site initiation visits, monitoring, all of the project management, people management, all of those are transferable skills that I use today. They're phenomenal skill set, and I think we really underestimate that within certainly our nursing delivery workforce, but the wider workforce. And so yeah, that was part of my clinical academic journey. And then I applied for and was appointed to a PhD studentship that was advertised and open to all professional groups, including medics, at the University of Nottingham. That was part funded by the NIHR, part funded by the hospital. And that allowed me to undertake the piece of research. It was called the Sketch Study, where we looked at longitudinal narratives of children and their significant others, which they defined in the survivorship journey post critical illness, predominantly focusing on psychosocial well-being. So that was the PhD journey, and I did that at the University of Nottingham, supervised by two incredible supervisors, Professor Sarah Edsell and Dr. Pippa Hemingway, who gave me real insight and exposure to other things, because neither of them worked in the paediatric critical care domain, but were both sort of child health researchers, one in the emergency department, one more sort of community health visiting focused. And then once I completed the PhD, I worked in a clinical academic post, which was 50% of my time was I continued to work as a research fellow at the hospital, at the university, and then half of my time as a clinical sort of researcher, but also working for critical care outreach, building, you know, and contributing and leading research, starting to sort of build capacity and capability within the hospital, and working with who was then the head of nursing and midwifery research, which was Professor Joe Cooper, who's now working at NHS England. So it was working with her and building the community of researchers across the whole continuum. And that was a sort of a trailblazing role, because it hadn't been done before, but it aligned to the ambitions of the organisation. And so I had opportunity to develop my leadership as a clinical academic, but also the both sides of the clinical role and also the research role. And then had opportunity to apply for a senior appointment. It was an associate professor equivalent, and then also working in the hospital. And that was an innovative sort of partnership between two universities, University of Coventry and also the University of Nottingham, and Nottingham University Hospitals NHS Trust. And there I was able to work with Professor Jane Code, because she was at Coventry University then, as the Associate Dean for Research, and also stay in the hospital and clinically based, as well as working at the University of Nottingham. And so I did that for a number of years. Whilst I was there, I applied for an NIHR clinical lectureship, and was appointed to that scheme, and then did that for 4 years. Well, initially it was for 3 years, but the pandemic hit, and so I had an extension to that because we had some challenge around the delivery of that, like many people who were on personal fellowships or delivering research during that time, or even doing studentships. So I completed that last year, and then I was appointed to my current role, which is 50% of my times at the hospital, 50% of my times at the university as the Professor of Nursing and Child Health. So that's sort of, it sounds relatively simplistic and very linear pathway, but it wasn't, in reality, it wasn't like that. And it was, a lot of it was negotiating, visioning, trying to change hearts and minds, and orientate people to a career pathway that was relatively unknown. And I think, I've published a paper on this sort of strategic development of clinical academic careers, which I think you could probably put it in the bio as well.
Yeah, will do.
But it sort of articulates some of the wider working around what people need to do to progress through a clinical academic career, and some of that will situate within the immediate team. It will be at service level, it will be at a divisional level, it will be at organisational level, and I think now we're working across systems. It's about working with system partners and really influencing at system and national levels, to make some inroads in getting these careers mobilised within your space or organisation.
So, a couple of questions. One, that role that you talked about, there was 2 universities and 1 hospital. Was that under a single contract, or did you have 3 contracts? Because within clinical academic careers, a lot of people end up with like 5 million contracts. So just curious for you whether or not you were able to, like you say, win the hearts and minds of people so that you had a single contract versus a multi. Which one was it?
It was a single contract.
Ooh, fancy.
So I think, it worked out that way. And actually, my host organisation was the NHS. And until I was awarded my professorial position, I continued to be in the NHS, and be on an NHS contract. And we had service level agreements with the different organisations and a memorandum to ensure that the deliverables and that everybody got what they wanted from that partnership. But I think that, again, it's about having people around the table and having those very explicit discussions around what is it that people want from this agreement, and trying as best as possible to make it a single job as opposed to 3 separate jobs with 3 separate masters. And it, the person who's trying to do that gets stuck in the middle a bit.
That would be my next question, is how did you or what would be your top tips then for those aspiring clinical academics out there to be that person in the room, in the center of the multiplicity of masters, to still be able to hold on to your core deliverables, but because the university value system versus the hospital value system, they don't really meet or even talk the same language. So, yeah, what would be your top tips on negotiating that?
Well, I think this comes back to this paper that I wrote about the ideas framework. So I think it's about, you really have to have those influencers, so that's the I, and your
Yeah.
enablers, which is the E, with you on your journey. So I talk about, for clinical academics, it takes a village. I'm not here as the professor now in my new role because of me, myself, and I. I mean, yes, I've made a significant contribution. I have, I've worked very hard, and I've, put in the hours, and I've made some sacrifices along the way, and I've been very clear as to where I want to go. But I'm also have been so supported and dependent upon the people around you. It takes a village, I say. It takes a village to create a clinical academic, or anybody, any leader. It takes a village. So it's about identifying who are your influencers and who are your enablers, to enable you to achieve your ambition, which is the A of the ideas framework. And your influencers and enablers may be the same people, but they may be very different people. So for me, on my journey, it was about my head of nursing, clinical head of nursing, who was Angela Horsley, who was the former head of children and young people's nursing at NHS England when she left her post. And so it was about, very early on, and this links back to the conversation that we had at the beginning, is about, don't be scared to reach out to people. So I think she was in post, she'd come new into post about 3 days, and I said, oh, I need a meeting with you. And I was a band 5 staff nurse, and so I had a meeting with her and said, this is where I want a clinical academic career. And she was like, I will, great, I will support you. I'm not quite clear she knew or I knew what that looked like, but I think it's just about articulating what is your ambition and getting people on page. And it took another 10 years to get to where, to the postdoc period. But I think just pinning your colours to the mast and being clear about, okay, this is my ambition. I don't know what it looks like. I don't know how to get there, but I'm just articulating that to you is really important. And then subsequently, through the other roles that I've had, they have been real enablers because they've been on page. They've been on my journey with me, and it's about people. Even though we work in a health system where it's constant surprises, isn't it? We don't know oftentimes who's going to come through the door, but people just don't like surprises. It seems a little incongruent. So, as best as possible, give people a heads up and bring people on your journey with you. And so people like Jane Code, Joe Cooper, other people, the chief nurses. It's about, those have been the influencers and enablers for me in my clinical academic career to enable me to get there. And that's not saying that they did the work for me, but they are around the table to advocate and to influence and to, ensure that, Joe Cooper's role was very much to get clinical academic careers embedded into the organisation. So she made sure it was on the strategy and the strategic plan. And that's really useful because then we can align your ambitions to that strategic plan, and it has more likelihood of being realised.
So do you think now compared to 5 years ago that nurses, midwives, allied health professionals who want to be clinical academics, do you think that they're still hacking their way through a jungle, or do you think there's a bit of a single track now?
I mean, I'm not deluded. I think we've still got some way to go. But certainly from when I started so I graduated and qualified in 2005. I think we are much further ahead than when we were then, but we've still got quite a lot to go. But I think the next, certainly in the UK, the next 5 years are going to be an interesting time, because there is so much focused support around how we can develop our health and care clinical academic workforce. And so I think there is no better time to be a nurse, midwife, or allied health professional working in this space, because I think there is the resource and opportunity for talented individuals to pursue this career pathway.
No, I would agree with you. I think the beginning of this year, from December through to now, it almost seems like on a weekly basis, the NIHR is like, here's this new non-medic blah, blah, blah that you can apply for to support and embed research in more people's career. And it's targeted at those other professions. Not that medics don't need support, because I think that's the other thing too, is a lot of times medics are like held up as this, and I know several of them, and their pathway isn't quite as robust as a highway as I think some people would like to believe. But I agree with you. I think things are changing, and they're changing quite rapidly, and that it is a very exciting and promising time to be developing nurse, non-medic researcher, whatever category you're in. Cool. Thank you for that. So one more top tip question. What would be the one thing that, if you had a time machine, you would go back and tell the 2005 version of you about becoming a nurse researcher in pediatrics?
I think the one bit of advice that I tell myself to this day is hold your nerve, and that's a mantra that my colleague Dr. Louise Bramley always tells me when I'm sort of getting a little jittery over certain things, is hold your nerve, because I think things will. And for me, things have always come to fruition. And if you get a knockback, or if you get a rejection, or if you whatever, it doesn't always plan out as you hoped. I think that happens for a reason. It either makes you better, or think differently, or more determined to succeed. And so I think just having that sort of pearl of wisdom, just hold your nerve, and it will all pan out, is probably what I would say to my 2005 self. But I don't think there is anything that I would change. I mean, I think things have happened, and my journey has occurred, and I have learned in every role that I've had, in every discussion or challenge or pushback, or it has built me to the person that I am today. And I have no regrets, and I'm as passionate as I was then about nursing, and the contribution that nurses can make, not just to patient outcomes, but to society. I'm as excited now about the opportunities that we have within our profession for research and careers that involve research, and the sheer variety of it's not just this linear track that you have to be an academic. You could be a clinical academic, you could be a research delivery leader, you could contribute in other ways, and I think we truly, innovation, as we come to again to fiscal challenge and challenge around how are we meeting the diverse needs of our population, we will see further innovation as to what our profession looks like and how we can meet those ongoing challenges. So I'm so incredibly proud, and it's always a privilege to be a nurse, to be practicing as a nurse, but also to be developing the science for our practice and for the practice of healthcare, and to be advocating for others now that I'm in a position of influence. So yeah, I have no regrets, and I'm just always very grateful. I love what I do, and I love the people that I work with, and I love the potential impact that we could make as a critical mass of nursing researchers, scientists, clinical academics.
Wow. I'm gonna take that snippet and just have it like as my mantra. Got me all fired up there. I think like I'm not being facetious here. I think like for me, in my world and my circles, I think it's just so I completely agree with everything that you said. Like, and it's one of the reasons like I purposely chose to become a nurse. Is because I think we bring something very different compared to what a doctor brings, and our role. And like, you know, you look back through the history books of roles of other nurses and how they influence not just in the hospital, but out in communities as well. And like our impact is quite high. And I think as a group, we often downgrade ourselves and allow other people to downgrade us. And it, to me, it's just so great to hear like your positive spin on things, because I think so much of not just in media but society and the world, it's just like, oh, knuckle draggy and everything is bad and horrible. So to have a positive spin, I'm like, yay.
I think oftentimes we are our worst promoters.
Yeah.
So I think, we can always find difference, and when I'm speaking to people, and it's easy to look for the difference, and oftentimes we pose the debate of, okay, well, let's find the difference between the multidisciplinary team and the medics do this, and it's quite corrosive, and I think what I would encourage us to do is to look for commonality and look at contribution that we bring to the table,
Yeah.
and frame our thinking around that for us to be most impactful in our science, we need to do it as a team, and that team is not just health professionals, but actually, patients and public. At the core of everything I do is children and families are participants, as in active participants, are co-producing, co-creating the outputs of that, but also working in that sort of intersectional space with technologists and communicators and basic scientists, as well as sort of other sociologists and people from business, because if we work in that way, then we're going to really maximize on the impact that we can have with the research or science that we're generating. So I think, look, oftentimes we're fixated on the difference because in somehow that elevates our status, but I would encourage, and how I sort of frame my thinking is let's look for commonality, let's look for synergy in how we can work together, whilst recognizing the individual contribution that those are either the methodologists or professions can make to the science.
I couldn't agree more. I've recently come across the word that you use there, intersectionality, and I have completely fallen in love with it, because I think it's so much of who I am and my core as well, and how I view the world. But I think, like you say, if you purposely choose to build a team around you that has more insights and from different angles or different experiences or different ways of thinking, yes, does it increase the complexity? 100 times yes. But our world is complex. These concepts are complex, and I think one of the things that really strikes me is that in the holy grail of research, so randomized control trials, they strip away all of the complexity in order to be able to stand on a column and say, yay, this thing works. but we don't know how it works in reality. And then, that becomes our evidence to make clinical decisions. And then people's journey gets can become really negative through a health challenge because they are complex. And so maybe that drug doesn't work in them because of their unique complexities, because they've got 15 things wrong with them instead of the one that was in the RCT. And I think if we're really going to move research forward, if we're really going to move our evidence base forward, we need to embrace the complexity rather than try and, like you say, categorize it and have it all separate to bring intersectionality into our research. So yeah, I agree. Excellent.
Well, I think we're evolving into that space, aren't we, with the recognition of hybrid trials and pragmatic trials and platform trials, so that we can achieve a more sort of realistic understanding of how interventions affect real world situations and real world people, as opposed to this sort of relatively deductive and simplistic. I mean, I'm not a trialist, so I speak from the peripheries here, and I have some great colleagues that are experts in this space. But you're right. The phenomena that we're contending with and trying to understand and intervene is complex phenomena, and so this isn't a drug interaction. This is people and experiences and emotions and wider contextual factors, as well as pre-existing events, as well as what's happening in the moment. It's multi-dimensional, and it's multifactorial, and I think that's why we probably have to use mixed methods research and approaches in my research, because that gives me a better handle of complex phenomena, and also in developing complex interventions that can hopefully have an impact on improving and optimizing experience and outcomes for the populations that we serve. So yeah, I completely align to what you're saying.
I think with that, we're going to start wrapping it up because time has flown by. I've just looked at the time and I'm like, "Brr." And I know you're a very busy fella, so I don't want to take up very much more of your time. Um, any last things that you'd like to share with everybody?
I mean, I think I speak and support and mentor a number of people in various organisations that are keen on getting involved in research. And I think if you've got if something has inspired you, or lit little candle in your brain around, actually I want to pursue or understand more, then there is so many people out there that would be encouraging, supporting, and happy to have a conversation. So I think it's just encouraging people to step out of maybe their comfort zone and reach out to people. And there's lots of people out there that would be very willing to talk to people about research. I know from the NIHR we've had an incubator that's funded specifically for nurses and midwives, and there is loads of resource, and there's a map for people to select and understand if there's anybody working in their sort of topic area or geography that they could reach out to. So I think, yeah, don't be afraid, and be bold. If you want a career that involves research, whether that's you could have a management career, nursing management career, that is also as a clinical academic. You could have an advanced practice career that's as a clinical academic. You could have an education career, clinical educator career, and also develop the science for your practice. So I think be bold and be visionary and think differently, because these are the people. We need people like that in our profession, because we're going to need people that cover both of those bases, or all of those bases, for the future, as I say, to meet the population health needs of today, but also the challenges of tomorrow.
Oh, thank you. It's a great way to wrap up what was a very fascinating conversation on like what clinical academic careers are about, as well as like your own journey into research. For everybody out there who's listening, all of the resources that we've kind of been mentioning throughout the podcast. So Joseph's research, I will put a special star by that paper that he's written around clinical academic career development, because I think that'll be a really good resource to anybody out there who is trying to follow the clinical academic career pathway. I know I've read it and loved it and have like notes scribbled all over it. And then the other resource that you mentioned, which I think is another really good link that I'll put in the description, is the NIHR incubator and that map and stuff, because I think it will help people start to, to be honest, everybody, if you just listen to this podcast and make note of all the names that Joseph has been like dropping in, you'll have loads to pick from.
Oh gosh, and there's hundreds more. There's hundreds more people.
I know. It's interesting. Once you start digging, you're like, all these people start popping up. So all of that will be linked into the episode. And you can access find him on his socials through there as well. So thank you so much for your time, Joseph. It was a real honor getting to speak with you and to learn more about your pathway. And even though it sounds, in theory, linear, I know it isn't, because I've been on that pathway. And I think your encouraging words to everybody out there listening of being bold and holding your nerve is such an important thing, because even though things are much better than what they were, we still are all trailblazing. And I think the more that we gang together, that we support each other, and that we develop those intersectionality relationships with other people who are trying to do the same thing, it's only going to help us grow in strength and number. So thank you so much for your time.
Oh, my pleasure.
And I'll see you online, definitely, but I have no doubt we'll bump into each other again in the future. So thank you so much, and I'll speak to you soon.
Thank you. Bye-bye.
Bye. Don't go away. Up next, we have the top 3 takeaways from this week's podcast by Dr. Rosalind Austin. I've been following Joseph for quite a while on social media, and I've always been impressed by his research and his journey as a clinical academic nurse researcher as well. So it was such an honor to have him come on this podcast and to share with me, and of course all of you, his journey, his challenges, and what inspired him, and how he got to become a professor as a clinical academic in nursing. So for me, my top 3 takeaways, first and foremost, have a low threshold for reaching out for help. I mean, it was brilliant. I really respect Joseph and how similar to me, he really does believe in that standing on the shoulders of giants. And if you have listened to the whole episode and made it to the top 3 takeaway, you'll have heard name after name after name of people that he's worked with, who's mentored him, who supervised him, who inspired him. This cluster of individuals who he's reached out to and who he's gone to through various different parts of his journey in order to get to where he's going. And he just kept reinforcing that over and over and over again. And while other people on the podcast have said similar, I really liked how he phrased it as having a low threshold for reaching out. So not so much worrying about having to be brave or speaking up or talking to a stranger, but just having a low threshold. Like, people are probably going to be quite happy to talk to you about their research, especially within my experience anyway. Everybody that I reach out to is very happy to talk about their research or the challenges they've had. So just having the gumption to reach out and have those conversations, I think, would be really, really helpful to anybody, no matter where you are on your research pathway. So that was number one, having a low threshold. Number two, which I wasn't expecting he would go there, but having an open mind when it comes to what outcomes and what methods you're going to use in your research. So his work, as well as some of his supervisors' work, has been very seminal around co-production, co-design, but also in using more creative research methods to look at people's experiences through healthcare. And in his case, it's children and their families. And he mentioned very briefly the use of art. And, you know, it is a new thing. It's not as recognized as like an RCT, but it is robust. There are good ways of doing that analysis, and looking at some of his work, which will be linked in the description, as well as some of those people that he mentioned through the podcast, would be really, really helpful. A person he didn't mention, who I've done a course with, which I found very inspiring, and I've got their book, is Helen Cara. And it's exactly that, using creative research methods in the social sciences. But it made me think, and I want to know what you guys think. So tell me in the comments, should I reach out to either Helen Cara or maybe Jane Coad to have them do a masterclass in creative methods? Yeah, so let me know what you think. The third takeaway, which I really liked, was his comment near the end when I asked him about his challenges and what he would say to the younger version of himself. And he said, he used the words, hold your nerve. And I thought that was a really, really good way of capturing it, because like we talked about in not just this episode, but loads of episodes, the pathway to being a researcher is challenging. There are rejections pretty much not even around a corner, just by the wayside. And it can be really hard, and it can be really isolating. And I really liked how he instead of talking about things like persistence or resilience, he talked about holding your nerve and not doing that as an independent person. You know, he mentioned he's got people around him who they're the ones who say to him, Joseph, hold your nerve. And I think that's so important. We can be so tempted, especially now, the post-COVID world, where more and more of us researchers are, to one degree or another, working in our homes, in remote locations, and aren't connecting into the office, to build around us these networks of individuals who, yes, mentor and inspire us, but more importantly, will be there through the tough times and to be a safe space for us in those tough times, to put an arm around us and to just say, hold your nerve. So yeah, those are my top 3 takeaways from this episode. Having a low threshold for reaching out, capture what matters to your population, and thirdly, holding your nerve and having somebody to help you hold your nerve are what really stuck out for me. At the time of recording this, it's March. I don't think this episode will be going out until about May, because I only do an episode every 3 weeks. But at this time, I've just reached a really exciting milestone, I would guess, which is 1,000 views on my YouTube channel. So thank you very much to everybody who's out there and who's watching the videos that I put out that accompany the podcast. If you're enjoying them on YouTube, please give them a like, comment, subscribe, because it will really help grow the channel, and it really helps it get underneath more people's noses. You can also share it with your colleagues as well. That would be really great. But thank you for all of your support, and especially all of the messages that I've been getting, whether they be public or whether they be private. It really means the world to me, and it helps keep me inspired to keep doing this. If you only listen, please remember on your podcasting platform of choice to follow the podcast, to leave a review, anything that you can do to help me out. I would really, really appreciate it. You've all been so great so far. So yeah, looking forward to seeing where it goes. That's it for this episode. I really enjoyed this. I found it so inspiring. He's so positive and views things with a real solution orientated focus. So yeah, definitely check out his research, check him out on social media. If you don't already follow him, definitely give him a follow, because he's a really interesting nurse researcher to follow. Until next time, I think that's pretty much it. And I hope that you have all enjoyed this as much as I did. And I will see you in another 3 weeks. Until then, remember to just keep asking why. Take care. Bye.